So, hello, I'm Michelle Edwards. I'm from Cardiff University, and I'm a research fellow in the Marie Curie Research Centre. And I joined a Horizon Europe and UKRI project called Serenity. It's a €6 million study, and we're looking at antithrombotic therapy. So we're looking at blood thinners in people who were towards end of life with cancer. And we're looking at making a decision support tool to help them make decisions about whether they should continue or stop. And so myself, as a research fellow, I lead PPI and I work on several of the work packages. Cathy Seven works alongside me as our lead public contributor, and I'll explain to you more about her role. And Ellen Badley works with me as well. And it's led from Leiden University and also from Cardiff University. So tell you a little bit about the study, and I'll tell you about how we're working with PPI on a multi-component, multinational study. And so the study is about taking antithrombotics near the end of life. And the reason why this study is important is because antithrombotics can be used to prevent blood clots, but they can also create a risk of excessive bleeding in this population of people near to the end of life. And so the bleeding can be quite catastrophic and fatal, and also, if not catastrophic or fatal, affect quality of life. And so we want to give people the information on the risks and benefits of taking this medication at this time. However, there is a lack of evidence to support clinical decision-making and also shared decision-making with patients and doctors coming together. And so it'll produce the evidence to provide into the tool with a variety of research methods across the multiple work packages. So we have PPI in all work packages to optimise the quality of our research and ensure that research processes are likely to be acceptable to participants, and that the tool we're developing will be appropriate for this study population. And so just to give you a little bit of a background about Horizon Grant. So Horizon Grant, €6 million. There's 8 or 9 countries on it. There's over 55 researchers in the consortium. This grant was obtained through a sort of organisation comes in and helps write the grant application. And public involvement was proposed in that grant application, and they proposed that there would be a 30-member panel in the project. And I'll go on to talk to you about that and about the feasibility of that. So a little bit about the complexity of the study and the design of it. So there was a realist review which looks at why, when and how to stop medicines in patients towards the end of life. And so that was being carried out and led by Hull York University. And then there was a survey that went out to like over 200 clinicians to ask about what their prescribing practices were and how they made decisions and kind of what results come out of their decisions. And then epidemiology study was taking place, looking at cohorts of people who had advanced cancer, who were on antithrombotics, to see what kind of happened to them. Did they have any bleeds or clots? And this involved sale. And so this cohort studies were being done in Wales, in Denmark and the Netherlands. And the reason for that was to sort of inform around risk information around to go in the shared decision-making tool. So how many people would have a bleed if they stayed on antithrombotics until the end of life, for example. And then there's qualitative studies with patients and clinicians to understand their views around taking antithrombotics at this time or stopping them. And that was to inform the decision tool. There is a Delphi survey going across multiple countries to lots of clinicians, which will sort of gather views to inform the development of the shared decision-making tool, and also how shared decision-making will be implemented in practice. And then there's a design and development team led by a private company in the Netherlands who are designing the tool. And we developing it, designing it, all the content. The Netherlands team was sort of putting it together, and we're kind of usability testing it and developing a version ready to be evaluated in a clinical trial. And you can see on my slide here, there's lots of different countries involved in this. And these work packages are being led by people in different countries to the UK, actually. So Kathy's role, so when I come onto the project, it was already funded. I was employed as a research fellow. We realised, we've got a lot of PPI work to get done on this project. And we recruited Kathy Seddon to work with us because Kathy had been involved in research on thrombosis for a number of years. She's involved with us at the Marie Curie Research Centre and also involved with the Wales Cancer Research Centre. So in Kathy's role, she attends all consortium meetings with over 55 researchers every 3 months. She attends the steering committee, where all the work package leads, their monthly meetings. She attends the trial executive committee meetings, which have just started because we're going to be starting the trial in a year's time. And she provides public contribution to all 6 work packages. And she's involved in all our publications that are coming out of the study. And she will review them and look at them and sort of contribute to them. And she'll be named as an author on all of them. And Kathy and I and Ellen had to plan all PPI activities for the whole study across all the countries involved. And we worked out a kind of strategic plan, how we're going to do that. And we had to survey all the different people leading work packages in all different countries to have a look to see how we can implement PPI in all these work packages. So Kathy's had the opportunity to attend national and international conferences, and she came to Switzerland with us in the summer, which was the conference on shared decision making, where she learned a lot about shared decision making, and she had the opportunity to network with other public contributors across Europe. And Kathy attends meetings with PPI groups, so I'll talk a bit more about that. We've had to go out to other groups to talk to them and involve them in Serenity. And we provide a newsletter to consortium members promoting the PPI work we've done. We provide training and advice to our European collaborators. We plan and track PPI across Serenity using PIRIT. We've been involved in reporting to the European Union on this. And we have just put out a paper for publication on our strategy. We're waiting to hear back about that, and we'll be producing more papers about how we're doing PPI in Serenity. So some of the activities we've been doing in terms of PPI, we were unable to compile a 30-person panel for PPI in Serenity because we had particular barriers where we were working with work package leads in countries where they don't use PPI, and sometimes where they do have PPI, we had people who weren't comfortable joining a panel where people had to speak in English. So it was a real challenge to sort of comprise a panel. And so what we decided to do is reach out to all our public involvement groups that we know of here in the UK or Wales and sort of ask them for involvement and advice and support with our project. And so we involved the Wales Cancer Research Centre PPI and some of the people from Hull York in the Realist Review in 2 workshops. And we had a Kathy kind of review and contribute to this flash mob study we did of practitioners. In the epidemiology, we had the opportunity to discuss some of the initial findings with a sale consumer panel, but we got extra value from that because on hearing about our project and some of our methods and what we're doing in the project, they gave us lots of additional advice about the tool and how useful it would be, and kind of whether it should be in particular languages or how it should be, what it should look like. And so we've been able to take that advice further on. And our PPI lead, Kathy, has contributed to some of our papers in this work package. And in the qualitative study, we've had Kathy and Rashmi Kumar who've been looking at the ethics applications, looking at our framework, discussing early findings and reviewing and contributing to papers. In the Delphi study, Kathy's been sitting on our Delphi steering committee, and we've had attendance from Rashmi as well. And they've been looking at edits to the Delphi survey and involved in contributing to a protocol and papers that will come out of that. And then we have Kathy alongside us on the development of the tool and all the content that's going in the tool. And so to discuss how that's designed, what it looks like, how accessible the language is. And we were also working with Valindra Voices. And so when we engaged with our Prime supergroup about our qualitative work, we talked to them about user testing as well. And it was suggested that we use the test with people who were really part of the target group or very close to the target group. And so we're using people who are cancer experienced from Valindra Voices to help us kind of assess the usability of the tool and what it looks like. And then, so Kathy's then joined the trial executive committee. We'd be looking at contributing to the tool design, and we'd be collaborating with public involvement, people from Leiden University to plan and implement the trial. So some of the comments we've had back is from our public contributors in the realist review workshop. People suggested it was really important to be mindful of people's needs and personal values and beliefs, and conversations around, medication prescribing and decisions should be focused on information about risks and benefits of medication, and also to be respectful of culture. And so to respect that patients' health needs and ensure and explain information is important, and to be mindful that some cultures it's more difficult to talk around death and dying, and there are people in those communities who kind of will help take on that role as well. And so having discussions with people in the workshops there helped the realist review writers sort of focus their writing and acknowledge the importance of these issues. So looking at when we engaged with the sale consumer panel, and we were looking at the study overall, we started talking about the study. People mentioned it was really important for us not to overload people with information at this particular tough time, and to make sure we keep our information simple and have options for pictures, and to make sure we use lay terminology. And so we would try to keep our information simple. We try to have visual representations of risk and also verbal representations of risk. We try and keep our terminology in plain English, and where it's not in plain English, we offer an explanation of what this means, such as what catastrophic bleeding means or what major bleeding means. It is described within the tool. And somebody also reminded us, will the tool be in Welsh? And these kind of questions that come up when we're engaging or involving consumer groups help keep these things in our mind. And we do realise now that this tool, if it's going to be used for testing in Wales, and it is going to be used as part of a randomised controlled trial in the Welsh NHS, it does need to be produced in Welsh as well. And we are talking to our app developers about that. So we engage with Prime Centre Wales when we were talking about the tool and how we were going to test it. And some of the members there reminded us that, we don't have cancer, you should be asking people with cancer, or people closer to that group, what they think of the tool, so test it out with them, use it with them. And so our first stage of usability testing really is just to see if the content looks okay, whether it functions quite well. We are using people with phalangral voices who have experience of cancer, but they're not our target group of people who are at end of life with cancer, but they understand cancer, they know about cancer services, and so they are providing their kind of unique perspective. And then when we go on to our next round of alpha testing, we are going to be targeting in clinics with people who have cancer and thrombosis as well. And so we were reminded that the tool needs to provide evidence on quality of life, and we have in the tool, we do have sections there which talk about how people might be affected and how their quality of life might be affected by staying on antithrombotic medicine or coming off it at this time. And we have used patient stories to show how other people are affected by these decisions as well. So just to have some kind of reflection on, the kind of things that we've been doing with Serenity. So we had to really create a flexible and responsive strategy for PPI. We couldn't implement this 30 person panel. And so we've had to sort of try and engage with people as we can and engage with the networks that we have in Wales. And we're really lucky that we have them. And we need a PPI lead with specific topic and a wide methodological expertise to embed PPI across the framework. So I'm a research fellow on Serenity, but I understand shared decision making. It's part of my background and advanced cancer and thrombosis. And so kind of my methodological skills help me work across all the work packages and understand the kind of needs for PPI and how they're going to be implemented alongside each work package, especially when I'm working with people who are not used to working with public involvement as well in other countries. And we needed a lead public contributor with substantial experience of PPI in this project because there was a lot of work to be done. And so, we were really, really grateful to Health and Care Research Wales for helping us recruit public members to help us with Serenity. And we really appreciate being able to engage with PPI groups such as the Sales Consumer Panel and Prime Supergroup, Phalangral Voices, and Wales Cancer Research Centre. PPI is needed at the grant writing stage at the very beginning of the study, and it wasn't really in Serenity, and I don't think the full scale of how PPI was going to be implemented on such a big European standard was going to how big it was going to be. And the Horizon programme, they don't really follow European UK standards on PPI, and so we've actually had to introduce that into the project. And so what we found is that public involvement, it was a work package in itself, and as big as all the work packages across Serenity. And we really feel that the funders really need to sort of be convinced of how big PPI is and what a big part it plays in a big project like that. And so, we had varying levels of experience working with PPI. And so we did have to have time to have a survey and training and awareness to sort of encourage our European partners to involve local people. And there was also varying capacity to coordinate PPI on a local level. And it's not always feasible to compile a European panel due to language problems and logistic problems. What we did find was that we tried to engage with some of the European organisations, but it was quite difficult to access them to sort of get people into a panel. And so we really, what we're learning is that early engagement is best, really back that grant writing stage before the project is funded, see if you can sort of feel it's feasible to get a big group of people across Europe. So PPI and Serenity is being led here in Wales and the UK, and we are aligning with the UK standards, and we're using PIRIT. And we're really grateful for all the engagements we can have with all the other PPI groups that we were able to network for Serenity. And it's going very well, and we're moving into a randomized controlled trial phase where we will be collaborating with PPI in the Netherlands, in Leiden University. And so that's all I have to say today, really. I just wanted to give you an example of some of the opportunities and challenges and working on such a huge study like this. And our next paper would be really to how can we advise funders and people who are applying for big grants like this to, make sure they get PPI implemented.